Thank you very much. And I want to thank the organizers for inviting me to give this talk. This is the same talk I'll be giving this afternoon. So for those of you who were thinking about coming to the scientific meeting later this afternoon at 2, you're now free to do something else. And this is the first time I've given this talk. So this was a really interesting exercise for me. In my group, and I don't think I'm going to insult anybody by saying this, I'm one of 2 child neurologists. My counterpart is Dr. Zarazwela Zolkipli Cunningham, who's the neuromuscular doctor. I like to think of myself as the brains and she's the muscle. Because I really focus on the central nervous system. So I really do think about the brain in terms of epilepsy, the stroke-like episodes, but here we're focusing on psychiatry and neuropsychiatry. And this was, as I said, a really interesting deep dive into the psychiatric manifestations in primary mitochondrial disease. So again, I can't thank the organizers enough for inviting me to give this talk because I learned a tremendous amount of information. So with that, try to see if we can advance the slides. My clicker is not working. I may need some IT help for the clicker. Oh, there we go. Whoop, too far. Okay, here we go. Okay, so here's what I learned when I started doing some background in checking when I went through the literature. So this was a really surprising statistic for me. Between 50 and 70% of patients with primary mitochondrial disease either have or will develop psychiatric symptoms at some point during their lifetime. And the 70% was more for the adult population and 50% was for the children. The flip side of that is that many people with primary psychiatric symptoms who are under treatment are not tested for mitochondrial disease. So if we look at psychiatric clinics or people who are under care, many of them may have a mitochondrial disorder and not know it. And then we have to look at people who have chronic disease of any type, and that increases the risk of developing disorders such as depression or anxiety. And this is very well known when you look at disorders such as multiple sclerosis, rheumatoid arthritis, any type of chronic disease. And there's an overlap of symptoms. And so when we look at symptoms of depression and symptoms of mitochondrial disease, there's a lot of commonalities such as fatigue, sleepiness, and things such as GI symptoms. So developing a poor appetite and weight loss. And how do you separate those out? How do you know if you have those symptoms, if they're due to depression or due to your mitochondrial disorder? So it can get a little bit messy in terms of trying to decide what are those symptoms attributed to. And so the bottom line from looking at any of these studies, and the conclusion was the same time after time in all of these publications, psychiatric disease in primary mitochondrial disorders is underestimated and therefore undertreated. And so we need to really take a closer look at this in our patient populations. One of the things that has come up for me when we look at our patient population, even if we go back to some of the animal models, is asking the question such as, is there selective vulnerability in primary mitochondrial disease and in certain disorders such as MELAS? And I think I stole that from Dr. Kozik. I heard him use that phrase at a talk that I heard him give probably 5 years ago. But one of the questions that comes to me in clinic when I'm sitting with my patients is, well, I know I have depression. I know I have anxiety, and I went to counseling and then I went to a psychiatrist and they were scared to treat me. They didn't know if the medications were safe. And then another question that comes up is, I didn't react to the medication the way they thought I should. Is there a different way that patients with mitochondrial disease respond to these medications? And one of the things that we're going to see in some of the literature was this treatment-resistant depression or treatment-resistant anxiety. And we're going to also hear from some of these other people this afternoon that I'm going to refer to because they've done a lot of work in this area. And we're going to talk about primary psychiatric disease and where we see some mitochondrial dysfunction in disorders such as schizophrenia, bipolar disease, and depression. So we can see evidence of dysfunctional energy metabolism in psychiatric disorders, including depression and bipolar disorder, things such as abnormal brain energy metabolism, abnormal electron transport chain function, abnormal mitochondrial gene expression in schizophrenia. And this was published in a nice review by Dr. Fernando Scaglia back in 2010. But this afternoon, we're going to hear from Dr. Anna Andriaza, who will be here from Canada, and she published this back in 2018. They've looked at brain sections and have seen abnormal complex 1 activity and oxidative damage to different mitochondrial proteins in schizophrenia and bipolar disorder and depression. Again, Dr. Andriaza published that in 2018. They've looked at muscle biopsy in patients with major depressive disorder and seen decreased ATP production, multiple mitochondrial DNA deletions, and decreased ETC activity. That was published by Dr. Gardner in 2003. Altered cerebral expression of mitoproteins in bipolar disorder and schizophrenia, altered energy metabolism in mood disorders using MRS in brain, and that was published by Dr. Cato in 1993, and he's joining us virtually this afternoon. So that's a very old paper. And then there are even some treatment ramifications from some of this work looking at mitodysfunction in primary psychiatric disease. So Dr. Cato did a study on polymerase gamma mice, and they showed recurrent spontaneous depression-like episodes that were prevented by an SSRI drug and worsened by lithium withdrawal. And then Dr. Fry, who will be joining us this afternoon, had this interesting paper, and he'll be talking about this specific issue today, antidepressants that increase mitochondrial energetics that may elevate the risk of treatment-emergent mania. So again, really bringing home this idea that mitochondrial dysfunction can really impact primary psychiatric disorders. I just wanted to also mention this because this is also another fascinating kind of side piece to primary psychiatric disorders. Dr. Lisa Pan, who is in Pittsburgh, published this article in 2017, and I was at the SIMD meeting when she announced the study. She looked at spinal fluid in 33 adolescents that had treatment-resistant depression and suicidal ideation, and found that 12 out of 33 of them had low folinic acid levels in their spinal fluid, and she treated them with folinic acid using Deplin as medication, and they all improved. And this is a biomarker that we use in mitochondrial disease. We know this is low in polymerase gamma and Kearns-Sayre syndrome. So this is a mitochondrial biomarker. And then just last year, along with Bob Navio, she published another study where they looked at metabolomics in blood in 99 patients with treatment refractory major depression and suicidal ideation. And to quote in the paper, pathways regulated by mitochondrial function dominated the metabolic signature, and this included elevations in FGF21 and GDF15. So again, we're seeing a lot of mitochondrial dysfunction in patients with psychiatric presentations. And again, Dr. Andriaza, who will be here this afternoon, this is a paper from 2016 where they were announcing a huge project that they're undergoing in Canada, discovering biomarkers for antidepressant response, a protocol from the Canadian Biomarker Integration Network in Depression, and clinical characteristics of the first patient cohort. And so they're looking very hard to find out what are the markers to determine who is going to respond to what medication, and looking for those biomarkers in a patient population. And I don't know if she's going to be giving us any updates on that project. So how did I come into this area? We did a project through the Mitochondrial Medicine Society several years ago, and we really were actually asking about fatigue in our patient population. And we wanted to explore fatigue and primary mitochondrial disease, but we wanted to find out what were the comorbidities that would interfere with our patients reporting on their fatigue, and what else would impact their fatigue. And we know that fatigue is one of the #1 symptoms in our patient population. So this was a multi-center project led by Sumit Parikh. And so it involved several of our centers. And we went through several outcome measures with our patients, and we asked them about fatigue several different ways because we were also checking into several different fatigue measures, including the fatigue impact scale, the checklist of individual strength, the fatigue severity scale. But we also used the Beck depression scale and the Beck anxiety inventory, along with the Epworth sleepiness scale to check on sleepiness, and the Newcastle mitochondrial disease scale. And the Newcastle scale, if you haven't heard of it, this is a way that we measure the disease severity of a patient with mitochondrial disease. There's one specific for pediatric patients and one specific for adults. And so this was a prospective study, and 48 adult patients were involved in the study, and nearly all of them reported fatigue. But what we found is that depression and anxiety were common in this patient population, and depression was reported in 52% of the patients. And we compared this to a patient population of MS, and this was higher than patients with MS. And that cohort had 34%. Anxiety in our patients was reported at 79%, so very high, compared to 73% in MS. And what we noticed is that as the fatigue scores went up, as the fatigue severity went up, so did the prevalence of the mood disorder, and so did the severity of their mitochondrial disease. And again, as part of our conclusions, we noticed that the mood and the sleep comorbidities were under-recognized and undertreated in primary mitochondrial disease. And we started recognizing that perhaps if we treated the sleep disorders and the mood disorders, that we could have an impact on fatigue and disease severity. Part of that project, when we did the fatigue paper, is that we had to go back and review the literature on fatigue, but not only fatigue, but also depression and anxiety in this patient cohort. So this was our first deep dive in this area. And we found one of this seminal paper that was written by Fatal et al. In 2006. And they looked at 19 case reports on primary mitochondrial disease and psychiatric disorders. And this was fascinating. 75% of the patients in this cohort had psychiatric presentations that preceded the diagnosis of mitochondrial disease by years. And the common findings were progressive dementia at an early age, a drop in IQ, which is not normal to happen, and certain abnormalities on neuropsychological testing, having numerous physical complaints that were really kind of some of the red flag symptoms that we are used to hearing in mitochondrial disease, such as fatigue, sensorineural hearing loss, muscle pain, exercise intolerance, those type of things, and then progressive diffuse atrophy on CT or MRI neuroimaging. And the conclusion from this literature review was to consider mitochondrial diseases as a possible diagnosis, especially if there are multiple comorbid physical symptoms. So this is a very nice paper. And then in this table, this is a review, this is a summary of some of the other literature that we had reviewed for that fatigue paper. And again, one of the things that I had noticed in doing this table was that a lot of the literature was done published before there was next-gen sequencing. And so there were a mix of patient population. And what I noticed is that a lot of the patients in some of these papers, it was a struggle to diagnose some of these patients. Some of them had biochemical diagnoses, or some of them had been diagnosed by using criteria such as the Thorburn or Bernier criteria. But then we started seeing more emergence of the molecular diagnoses. But just to walk you through this, these were really interesting papers. So Fatal then did another paper the year later in 2007, where they had 36 adults. And the cohort here was adults that had primary mitochondrial disease. And here again, the psychiatric symptoms preceded the diagnosis of mitochondrial disease on average by about 8 years. And they took those patients and did a mini international neuropsychiatric interview and a score called an SF-36 to look at their quality of life. And here they found about 54% had depressive disorder, 17% bipolar disorder, 11% panic disorder. So again, these are not small numbers. And at the bottom, what you can see, it's a little bit covered up by the closed caption here, but mood disorders were very prevalent, more than the general population, and any disease controls. And a lot of these studies use disease controls, such as another neurologic disorder or chronic disorder, such as MS. I'm going to talk about Eva Morava's paper here from 2010. They used other genetic disorders such as Soto syndrome in that particular paper, but everyone used a different disease control to compare these scores, and the mitochondrial population was always higher in terms of mood disorder. Saskia Conan's paper in 2009, they sequentially looked at 218 children coming through who are undergoing a primary mitochondrial disease diagnosis. And 35 of those children were eventually given a mitochondrial diagnosis. And they had children that were 2 to 18 years old that were eventually diagnosed. And they had 2 children that had 3460, 2 children with 8344, and 1 with POLG. And they had outcomes such as the Newcastle scale, and then they had a few other scales to look at their mental health, including Hamilton, Zung, and life events. And the results were interesting because those 5 children that I highlighted here that were diagnosed with depression, they were all teenagers that were female. And they highlighted the fact that they were all female adolescent girls. And the one with POLG, before she had her mitochondrial diagnosis, was treated for mental health issues with valproic acid and had passed away from liver failure. And so they highlighted in this paper the importance of getting a genetic diagnosis because the treatment ramifications can become life-threatening. And so that was a very important paper. Eva Morava's paper in 2010, they had a cohort of 68 children and very carefully screened them. They wanted to make sure that the children were able to go through the different testing, and they used a child behavior checklist. They looked at children that were intellectually capable of doing some of the testing and came up with 18 children in the cohort, and then looked at different types of depression, either major depression or depression with withdrawal type symptoms. And the range was 50 to 67% had depression and 22% with anxiety. And then there was a paper by Englund et al. In 2012, and this was kind of now more emerging. This was a Canadian study, and this Englund paper in 2012 and the Rosebush paper that followed in 2017 was part of the same cohort. The Englund paper was 47 patients in total because they took a lot of patients from prior reviews, but then 12 new patients in the literature. The paper that followed was a follow-up prospective study. And these were all adults that had a primary psychiatric diagnosis, later diagnosed with primary mitochondrial disease, but 15% of them were treatment resistant, and 44% had depression, 34% with psychosis, 12% with anxiety. But what was important here to highlight is that about 55% of these patients in the total cohort had MELAS, and 18 of them had the 3243 common mutation. And they pointed out that several of these patients worsened with standard treatment, that again, the psychiatric symptoms predated the mitochondrial diagnosis on average of 13 years, which again, I think is very important to highlight. And again, that we now recognize that several of these genetic disorders, MELAS in particular, has a very high psychological burden. Okay, so that's a lot of the history of the literature. There are a few other papers that have come out singling out specific genetic diagnoses, because what I just presented, a lot of those papers had a collection of different genetic diseases. This was a more recent paper by Omar Hikmat's group, and Omar Hikmat has done a tremendous amount of work in Norway about POLG. And here they were looking at mental health and health-related quality of life in mitochondrial POLG disease. And this was a cohort of 15 patients, 10 females and 5 males. The age range at disease onset was 5 to 71. When they did the study, the age range was 16 to 83 years of age, and they did a symptom checklist, 90 questions, and then SF-36 for quality of life. And on the left are the symptoms, but I'll really just turn your attention to the right side of the screen. The orange line is the normal population in Norway, and the blue line are the POLG patients. And across the board, you can see the POLG patients are scoring lower, whether we're talking about physical symptoms or mental health symptoms. And so, again, we're all recognizing that we need to do more for the mitochondrial disease patients, no matter what the disease is. This is a paper that was talked about yesterday by 2 people, Rebecca Ganetsky as well as Elizabeth Reynolds. And this is a paper that was published in 2021 talking about SLSMIDs, the single large-scale mitochondrial DNA deletion syndromes. And this was a paper looking at the registry data from the CHAMP Foundation. It was pointed out yesterday that the disease burden here is very big. There are, on average, 42 problems across all organ systems, and patients on average have 3 major interventions, whether we're talking about a pacemaker placement or cochlear implant. But one of the things that was really highlighted in the registry was that 69% report at least one psychiatric problem, and 50% of that were anger or rage outbursts or distractibility or some type of perseveration. So going over things over and over again. But in terms of interventions, only 26% of patients were having some type of mental health intervention. And so there's a huge discrepancy there. If there's 70% having a problem, but only 26% seeking an intervention. And Dr. Ganetsky talked yesterday about the natural history study, and 4 out of 26 were reporting anxiety, and we may be underestimating those numbers. And this is just a little bit of an update on the CHAMP Perspective Natural History Study. On the left is a survey that we did one time. There was a day at the zoo that we had for our patients when we had an in-person meeting. And this is a multidimensional anxiety score. And there's on the y-axis here, there's 50% is the normal. I hope you can see the numbers there, but I'll just turn your attention to the top of the screen on the left, and you can see very high numbers here for things like anxiety, social phobia, obsessive compulsive disorder in children who have single large scale deletion disorders. And on the right side of the screen, this is now part of the natural history study. 22 patients are completing the IPMDS, which is International Pediatric Mitochondrial Disease Scale that was created in Nijmegen. And one of the questions is, has your child been depressed, sad, withdrawn, anxious, or quiet? And 0 gives you not more than peers. Anything over a 1 is only in specific circumstances, and then it just gets higher and higher after that. But what was answered among this patient population is 50% had levels of depression and or anxiety more than their peers. So again, another disease group where we're seeing this is a symptom that is needs to be addressed. So what about our patient cohort at CHOP? We just queried our database, and I am able to look into our database at my center, and I can put in definite diagnosis of primary mitochondrial disease, put in depression or anxiety, and then I can even look at medications. And this is my patient cohort, and we have 516 definite diagnosed patients. Of those, 65% have a diagnosis of depression or anxiety included in their problem list. I know this is an underestimate because, again, one of the issues here is that this diagnosis has to be in their problem list for me to get it out of the database. So that's problem number 1. We have 38 females and 27 males as part of that 65. And the bubbles kind of represent the numbers. So the biggest bubble here is MTTL1. the majority of those are going to have the 3243 common mutation that is responsible for MELAS, or maternally inherited deafness and diabetes. So we have 15 patients there, again, who have depression or anxiety as a problem. The green bubble on the top left is POL-G. The other one that has 5 patients is MT8, ATP6. And then we can see anything that doesn't have a number, we have 1 patient each. And so we have quite a few patients that have a few in different bubbles, but I thought that having 15 for the MTTL1 was pretty appropriate. And then if we query different medications and we could break it down based on depression or anxiety, we have quite a number of patients that are on SSRIs or SNRIs, different medications across the board. But there's a lot of work for me to do here, because I would like to see whether patients were started and stopped. I need to look into treatment resistance based on genes. So I have a lot of information in my database, but again, I want to go through different numbers, making sure that people have the diagnoses on their problem lists and be able to tap into this a little bit more. So we're just at the very beginning. But one of the things that we're going to do now, what else can we do? Well, we already are sending surveys to our patients, and we're asking them about their quality of life and fatigue and how they function. And we can send out a GI survey. But one of the things that we're going to be able to do is start sending them a DAS survey. And the DAS survey will start asking people about their anxiety and depression. And this is a little menu that our patients can get, and they're able to now choose whether they want to answer questions about their anxiety or depression, or they can get an invitation and say, your doctor would like you to fill out the survey answering questions about your anxiety and depression. So it can go either way. So this is a little cartoon that we like to show when we give talks about all the different organ systems. But I think one thing that I've been missing about what specialist people need are psychology and psychiatry. And again, I think we've greatly underestimated the need here for a long time, but that is no longer, because I think we definitely need to highlight this more. One of the newer papers that I am not showing is Michio Hirano's group has a new paper that has just come out showing how a patient's mood on any given day, whether you're having a good day or a bad day, can really determine how you decide your symptoms are that day. So if you're having a good day and you're in a good mood, you may decide your fatigue is better. But if you're having a bad day, you might decide your fatigue is much worse. And so if we're asking patients to report on their symptoms, especially for a clinical trial, well, we have to help people feel better if we're going to help them determine that their symptoms are better. So this is vitally important at this stage of the game. So I have a lot of references, and I have an incredible team at CHOP. I think you've met lots of people who are here, and this is my incredible clinical research team. And this work that we do at CHOP would not be able to happen without everybody. So I want to thank you for your attention.